Welcome back to the deep dive. Today, we are undertaking, well, a really essential mission, I think. We're digging into a pretty comprehensive set of notes all about peripheral vascular disorders, or PVD. These are conditions that really, at their heart, represent failures in the body's circulation, outside of the heart and brain. Our goal here is to cut through some of that complexity, give you a clear, structured way to think about how these issues show up, and importantly, how they're managed.
Absolutely. And I think it's vital right at the start to make a really key distinction. It kind of underpins everything else we'll talk about. When we talk PVD, we're looking at two fundamentally different kinds of problems, almost like plumbing issues. You've got arterial disorders. That's about inflow, getting the oxygen-rich blood to the tissues.
And that's a supply.
And then you have venous disorders. That's about outflow,
Right.
getting the used blood and fluid away from the tissues.
Blood turn.
Exactly.
Yeah.
And mixing those up, well, that leads to problems, misdiagnoses, treatments that just don't work.
So, inflow versus outflow. That's our starting point. And since this is a deep dive, we should probably start with the most common, maybe the most dangerous side, the inflow problem.
Makes sense. That means starting with peripheral artery disease, or PAD.
Okay, PAD. And for you listening, we really want to go beyond just definitions today. We want to make sure you grasp the mechanisms, the urgency around some of these conditions. So let's start that journey into the arteries. What's the main culprit behind PAD?
All right, PAD. We know it's progressive, a narrowing and deterioration of the arteries. But if you had to point to the single root cause, the mechanism that kicks this whole thing off, what is it? And why the periphery specifically?
Well, the mechanism is atherosclerosis. It's essentially the same process that causes heart attacks and strokes, but happening in the limbs.
So like coronary artery disease, but in your legs, for example.
Exactly. Think of your arteries like high-pressure pipes. Atherosclerosis is that buildup of gunk fatty plaques, cholesterol, calcium sticking to the inner walls.
Like sludge in a pipe, pretty much. And it's progressive. It can start really subtly, maybe decades before you even feel anything. But eventually it restricts that essential flow of oxygenated blood. And the tissue downstream, well, it starts to suffer.
And does this plaque just build up anywhere, or are there specific spots it prefers? Our notes seem pretty specific.
That's right. It often targets major branching points or areas where there's more mechanical stress on the artery wall. So clinically, we often see it in the aortoiliac segment, that's down in the pelvis.
Okay.
And then moving down the leg, the femoral artery, the popliteal behind the knee, and then the tibial and peroneal arteries further down. If you block those main highways, the whole limb is affected.
What's really striking in the notes is how many cases seem to fly under the radar. It says PAD usually shows up between 60 and 80, but many people, maybe most initially, just don't get diagnosed. Why is it missed so often?
Yeah, it's often a perception issue. Someone feels a bit of leg discomfort, maybe some fatigue when they walk, and or sometimes even their doctor, just chalk it up to, oh, I'm just getting older, or I need to get more active.
Right, the normal aging trap.
Exactly. They don't recognize that specific discomfort as a signal of oxygen deprivation ischemia. And because it's progressive, by the time the symptoms really become noticeable, maybe even debilitating, the underlying damage to the artery is often quite advanced.
Which leads us straight to the risk factors. And this list, it reads like a who's who of modern health challenges. Smoking, high cholesterol, high blood pressure, diabetes, they're called key risk accelerators. It sounds like a vicious cycle.
Oh, it's more than a cycle. It's like a systematic attack on the blood vessels. Each one contributes uniquely. Smoking, for instance, that's the single most powerful modifiable risk factor.
Right.
The chemicals directly hammer the endothelium, that delicate inner lining of the vessel.
Okay.
High blood pressure causes physical stress, shear force, injuring the walls. High cholesterol provides the building blocks, the fat, for the plaque itself.
And diabetes.
Diabetes is a big one. High blood sugar actively speeds up all those atherosclerotic changes. If someone has, say, 2 or more of these factors, smoking and diabetes, for instance, the timeline for plaque buildup gets dramatically shorter.
And that quicker progression, that's why PAD is such a huge warning sign systemically, isn't it? If the pipes to your legs are getting clogged.
What about the pipes to your heart and brain?
Exactly.
That's the critical takeaway here. PAD isn't just a leg problem. It's a marker for systemic disease. Studies consistently show PAD patients have a much higher risk of dying, usually from heart disease or stroke.
Wow.
So if you find significant PAD, you have to assume the coronary arteries are at high risk too. It demands a really aggressive, whole-body approach to management, not just focusing on the leg symptoms. Hashtags tag 1.2 classic and critical symptoms of ischemia.
Okay, let's talk symptoms then. The classic one, the hallmark symptom everyone looks for with PID is intermittent claudication. Can you describe that pain for us? Make it vivid.
Right. Intermittent claudication is very specific. It's an ischemic muscle pain, usually a cramp, often in the calf, but could be thigh or buttock. And it has two defining features, absolutely non-negotiable characteristics.
Okay, what are they?
One, it's reliably brought on by exercise, like walking or climbing stairs. Two, it's consistently relieved by rest, usually within just a few minutes.
So why does it start with walking and why does just stopping make it go away?
It comes back to supply and demand.
Hmm,
When you walk, your calf muscles need, let's say, 3 times more oxygen than when you're resting.
okay.
But if that main artery, the femoral artery maybe, is 70% blocked, it simply can't deliver that much extra blood. It can only deliver maybe 1.5 times the resting amount.
Mhm.
The muscle goes into oxygen debt.
Ah,
So to keep working, it switches to anaerobic metabolism working without enough oxygen. And the waste product of that is lactic acid. That buildup of lactic acid is what causes that intense ischemic cramp.
makes sense.
Then, when you stop walking, the muscle's demand for oxygen plummets. The body gets a chance to clear out that lactic acid, and boom, the pain disappears pretty quickly.
And that pattern, pain with activity, relief with rest, that's what really separates it from, say, arthritis pain, which might linger.
Precisely. Arthritis pain might change with position, but it doesn't usually vanish completely just by standing still for a minute or two. Now, while claudication is the classic symptom, the notes also mention sensory issues, paresthesia, numbness or tingling.
Yeah, in the toes or feet. And the implication of losing sensation there, especially with poor blood flow, that seems huge.
It's a silent danger. If someone has chronic numbness, they might step on something sharp or get a blister from a shoe or even a minor burn and just not feel it.
Right.
In a healthy person, a small wound heals. But in a paid patient, that compromised circulation means healing is incredibly slow or maybe doesn't happen at all. So an unnoticed injury can quickly get infected, turn into an ulcer, and potentially risk the whole limb, all because it couldn't feel the initial problem.
That's frightening. And then there's the next step up in severity, pain at rest. This sounds as more than just discomfort. This is critical ischemia.
Yes. Rest pain means the blood flow is so severely reduced that even the basic metabolic needs of the tissues just keeping the cells alive at rest aren't being met.
Wow.
The cells are literally starving for oxygen, 247. This pain is typically felt in the most distal parts, the toes or the forefoot. And critically, it behaves in a very specific way depending on position.
And this is where gravity comes into play, right? The notes say it often gets worse at night when lying flat.
Think about it. When you stand up, gravity gives what little blood flow you have a tiny assist down towards your feet. It's not much, but it helps.
All right.
When you lie flat supine, you lose that gravitational pull entirely. Blood flow drops to its absolute lowest. Patients often describe having to dangle their foot over the side of the bed or even get up and walk around just to get gravity working for them again and ease that agony.
And elevating the leg makes it worse.
Absolutely. Elevating the limb is the quickest way to further starve the already oxygen-deprived tissue. It actively fights against arterial inflow. Rest pain is a major red flag. It signals critical limb ischemia and an urgent need for intervention, usually surgical, to restore blood flow. Hashtag 1.3 physical assessment findings and complications.
Moving on to what we might actually see or feel during an assessment, the signs of chronic low blood flow often show up on the skin, right? Thin, shiny, taut skin, and hair loss on the lower legs.
Yes, those are classic signs of chronic tissue malnutrition. Skin and hair follicles need a constant supply of oxygen and nutrients to stay healthy and grow. When that supply is chronically cut back because of arterial blockages, the tissues basically atrophy. They get thin, fragile, and the hair just gives up and falls out.
It's a visible sign of the underlying problem.
Definitely. And seeing that atrophy is a key clue pointing towards arterial disease. But the core physical assessment is checking the pulses. We expect diminished or maybe even absent pulses, pedal, popliteal, or femoral.
And the notes are very specific about how to check pulses if they're hard to find.
Absolutely crucial. You always try to palpate, first feel for the dorsalis pedis on top of the foot, the posterior tibial behind the ankle bone. If you can't feel them easily, you must use a Doppler device.
The handheld ultrasound thing.
Exactly. It uses sound waves to amplify the sound of the blood flow so you can hear the pulse even if you can't feel it. And here's the critical procedural point. Once you find that pulse with the Doppler, you must mark the spot with an X on the skin.
Why DX?
So the next person assessing the patient and the nurse, a doctor can find that exact spot quickly and easily. It ensures consistency in monitoring changes over time.
Makes sense. And what if you can't find a pulse, even with the Doppler?
That's a critical finding. It needs immediate reporting to the medical team. An absent pulse, especially if it's a sudden change or comes with severe pain, could mean an acute arterial occlusion, like a clot has suddenly blocked the artery completely. That's a limb-threatening emergency requiring immediate action.
Okay. Then there are the color changes. This sounds quite dramatic. The foot looks pale when you lift it up, but turns really red when you lower it.
That's called dependent rubor, or sometimes reactive hyperemia. It's a striking visual. When you elevate the leg, gravity works against the already weak arterial pressure, so the foot blanches, turns pale, whitish.
Okay.
Then, when you put the leg in a dependent position, like hanging it off the bed, gravity gives it that assist and blood rushes in. But because the tissues have been starved for oxygen, the tiny arterioles have opened up as wide as they possibly can. They're maximally dilated, trying desperately to grab any oxygen that comes along.
So when the blood finally gets there,
It rushes in forcefully, and because the vessels are wide open, it kind of pools there for a moment, causing that deep, dusky, purplish red color. It's a very clear sign of severe arterial insufficiency.
and if this poor blood flow continues, the outlook seems pretty grim according to the notes. Delayed healing, ulcers that won't heal, tissue death, gangrene.
And ultimately, potential amputation if we can't restore blood flow or revascularize in time. That's why diagnosis and treatment before we reach that point of no return are just so critical.
So how do we actually measure how bad the blockage is without doing surgery right away? The notes point to the ankle brachial index, the ABI, as the first step, a non-invasive test.
Right? The ABI is simple, but gives us incredibly valuable information. You just need a regular blood pressure cuff and that Doppler device we mentioned.
Okay.
You measure the systolic blood pressure in the patient's arm, the brachial artery. Then you measure the systolic pressure down at the ankle using the tibial arteries. In a healthy person, the pressure should be pretty much the same, or even slightly higher in the ankle. So the ratio, ankle pressure divided by arm pressure, should be 1.0, or maybe a little higher.
Like checking the water pressure at the tap versus where it enters the house?
Exactly like that. It's a basic plumbing pressure check.
So what does it mean if the ABI score is less than 1.0?
That tells us the pressure in the ankle is lower than in the arm, which confirms there's a flow problem, a blockage somewhere upstream between the arm and the ankle. Our notes give a severity scale. 0.91 to 0.99 is borderline. 0.71 to 0.90 is mild to moderate PAD, but anything below 0.40, that indicates severe critical limb ischemia.
So that number gives us an objective measure of how bad it is.
Precisely. It helps quantify the disease and track its progression or response to treatment.
Now, if the ABI confirms PAD, the next step is often getting a better picture, a map of where the blockages are. The sources list duplex imaging, angiography, and MRA.
Right. Duplex imaging is great because it's non-invasive. It uses ultrasound with color Doppler to actually visualize the blood flow, see where it speeds up or slows down around a plaque.
But angiography or MRA give more detail.
They do. They provide those really high-resolution road maps of the arteries, which are usually needed if you're planning a surgical intervention like a bypass or angioplasty. But, and this is a big but, both angiography and MRA often involve using contrast dye.
And that brings up safety checks.
Absolutely critical safety checks. Before injecting contrast dye, you always need to assess the patient for allergies specifically, a history of reactions to shellfish or iodine, as they can cross-react with the dye.
Okay, allergies. What else?
Even more vital, perhaps, is checking their kidney function, usually with blood tests like creatinine and BUN levels. Contrast dye can be toxic to the kidneys, nephrotoxic.
And PED patients might already have kidney issues.
Very often. Many have long-standing high blood pressure or diabetes, both of which can damage the kidneys over time. Giving contrast dye to someone with already compromised kidneys without checking first puts them at high risk for acute kidney injury. That can be serious, even life-threatening. So checking allergies and kidney function beforehand is absolutely non-negotiable.
Okay, diagnosis confirmed, map obtained. Now, management. The goal seems huge. Improve blood flow and aggressively tackle all those risk factors we talked about earlier.
Yeah, this is where the patient really has to be on board. The sources lay out 4 key areas for aggressive risk factor reduction. First, stop smoking completely. No cutting back, just stop.
The #1 priority.
Absolutely. Second, blood pressure control. Meticulously managed, aiming for 130/80 mmHg or lower. Third, diabetes control. That HbA1c, the average blood sugar over 3 months, needs to be kept below 7%. And fourth, aggressive treatment for high cholesterol. hyperlipidemia, usually involving strict diet changes and statin medications to lower LDL cholesterol and stabilize existing plaques.
It sounds like managing those four is essential to slow things down.
It's the only way to really prevent or slow the progression towards critical limb ischemia. You have to tackle the underlying drivers.
Let's get into the medications specifically for PDAY. First up, preventing clots forming on those rough plaques. Antiplatelet agents like aspirin and clopidogrel.
Yeah, these are pretty much standard care for most PAD patients. That rough plaque surface is like Velcro for platelets. They want to stick to it and start a clot. Aspirin and clopidogrel make the platelets less sticky, significantly lowering the risk of a thrombus forming right there in the artery and causing a sudden, complete blockage.
Okay, antiplatelets. Then the notes mention ACE inhibitors like ramipril. I usually think of those for blood pressure.
They are used for blood pressure, but in PAD patients, they have added benefits beyond that. ACE inhibitors like ramipril seem to improve the function of the endothelium, that vessel lining. They can actually increase blood flow a bit, and studies show they can increase how far patients can walk before the claudication pain starts. Plus, they lower overall cardiovascular risk.
Interesting. And what about drugs specifically aimed at relieving that claudication pain? The notes mention cilostazol and pentoxifylline. How do they work differently?
So cilostazol is generally considered the first-line drug, specifically for improving walking distance in patients with claudication. It works in a couple ways. It's a vasodilator, so it helps relax and widen the blood vessels,
Okay.
and it also has some antiplatelet effects. By opening up the arteries a bit more, it helps maximize the blood flow that can get through those narrowed segments. Pentoxifylline works differently. It targets the blood itself. It actually increases the flexibility of the red blood cells, makes them kind of squishier. Yeah, so they can deform and squeeze through those really narrow, tight spots in the arteries and capillaries more easily. It also decreases the overall thickness or viscosity of the blood. Basically makes the blood flow a bit better, especially in the microcirculation.
Got it. Now, moving beyond medication, the notes highlight exercise therapy as maybe the most effective non-drug treatment. That seems counterintuitive. If walking causes pain, why make them walk more?
It does seem backward at first glance. But exercise is essentially how the body builds its own natural bypasses. The protocol is quite specific. Walk 30 to 60 minutes a day, at least 3 to 5 times per week, and stick with it for 3 to 6 months minimum.
And the key is how they walk, right?
Exactly. The technique is crucial. You encourage the patient to walk till they feel that claudication pain starting.
Okay.
Then they stop and rest just until the pain goes away. And as soon as it's gone, they start walking again. Repeat that cycle for the duration of the session.
So you're intentionally pushing into that pain threshold.
You are. Because that temporary ischemic stress, the muscle demanding more oxygen than it can get, is the signal that forces the body to adapt. It stimulates the growth of collateral circulation.
New blood vessels.
Essentially, yes. Tiny new blood vessels sprout and grow around the main blocked artery, creating alternative routes for blood flow. Over time, this natural bypass network develops, and it significantly increases the distance the patient can walk without pain. It really works, but it requires commitment.
That's amazing. And finally, the management plan includes nutrition. Seems like common sense, but what are the specific targets?
It ties right back into reducing those risk factors. The goals are clear. Aim for a BMI under 25. Cut way back on saturated fat and sodium. Keep dietary cholesterol intake low, under 200 milligrams per day. And the sources specifically mention waist circumference targets less than 40 inches for men, less than 35 for women.
Why waist circumference?
Because that belly fat, visceral fat, is metabolically active. It churns out inflammatory substances that directly contribute to vascular inflammation and the progression of atherosclerosis. You can't really fix the plumbing if the stuff flowing through it is constantly causing damage. Hashtag take 2.3 surgical and post-procedure care.
Okay, so lifestyle, meds, exercise. But what happens when that's not enough? When someone has severe claudication that limits their life, or they develop rest pain or ulcers, surgery becomes the option.
Yes, at that point, when we're talking critical limb ischemia, the goal shifts entirely to revascularization, actively restoring blood flow to save the limb. The procedures vary. You have less invasive options like percutaneous transluminal balloon, angioplasty PTA, where they thread a catheter in, inflate a balloon to squash the plaque against the artery wall.
Like a roto-rooter.
Kind of. Or atherectomy, where they actually use a device to shave or cut out the plaque. Then there are more major surgeries like bypass surgery where they use a graft, either a synthetic tube or one of the patient's own veins to create a detour around the blockage. Or endarterectomy, where they surgically open the artery and scrape out the plaque and diseased lining. Amputation, thankfully, is really the last resort, only considered when infection is out of control, or blood flow just cannot be restored, and the tissue is dying.
And the notes mention that accessing the arteries for many of these procedures often involves an incision in the groin to get to the femoral artery.
That's a very common access point, yes, which means post-procedure care is absolutely critical and requires intense monitoring.
What's the main focus after surgery?
It's all about making sure that newly restored blood flow stays flowing. We're constantly monitoring the limb. We look for the classic signs, sometimes called a pis pulse, pallor, paresthesia, sensation, and pain. We're checking skin color, feeling the temperature, assessing pulses, frequently comparing the operated leg to the other leg.
And if something changes, like a pulse disappears?
That's an emergency. If a pulse that was present after surgery suddenly vanishes, or the limb becomes cold, pale, or excessively painful, it could mean the angioplasty has failed, the bypass graft has clotted off, or a new clot has formed. It requires immediate notification of the surgical team.
Got it. And the notes have some really specific don'ts for post-op care, like absolutely avoiding knee flexion. Why is that so important?
Especially if the surgery involved the femoral or popliteal artery near the knee, or if a bypass graft crosses the knee joint. Bending the knee sharply can kink or compress the artery or the graft at the surgical site.
Ah, cutting off the flow you just restored.
Exactly. It could cause the vessel to occlude or put dangerous stress on a new graft. It can be catastrophic.
Yeah.
So patients need careful positioning, often keeping the leg relatively straight or only slightly bent.
And another specific point, use warm blankets, not heating pads. Why the distinction?
It comes down to safety and sensation. Applying external warmth can help promote vasodilation and improve circulation, which is good. But PAD patients often have two problems: severely compromised circulation and neuropathy or paresthesia, meaning impaired sensation.
So they might not feel if the heating pad is too hot?
Precisely. They could easily get burned without realizing it. And because their circulation is already poor, that burn might not heal well, leading to a serious ulcer. The risk of causing a burn outweighs the potential benefit of direct heat. Warm blankets provide gentle, diffuse warmth, which is much safer.
Okay, so PAD is about chronic blockage, but not all arterial issues are like that, right? The notes mention Raynaud's phenomenon. This sounds different, more like a temporary spasm.
Exactly. Raynaud's is a classic example of a vasospastic disorder. It's not about a fixed plaque blockage like PAD. Instead, it involves these sudden temporary episodes where the small arteries, usually in the fingers and toes, clamp down intensely. They go into spasm.
And it affects a different group of people, too.
Yes, typically much younger than PAD patients. Primarily young women, often starting between ages 15 and 40. That's a big clue it's not atherosclerosis.
And the triggers are different, too, not necessarily activity, but things like cold or stress.
That's right. The triggers are often exposure to cold temperatures, emotional stress, sometimes even things like handling vibrating tools or stimulants like smoking or caffeine. Basically, the sympathetic nervous system overreacts, causing those small arteries to constrict dramatically.
And the symptoms are quite characteristic, that color change sequence.
Yes, the classic sequence is really diagnostic. It usually starts with the fingers or toes turning white.
Pallor.
Right, that's the vasospasm, cutting off blood flow completely. It often comes with numbness, tingling, a dead feeling. Then, as the trapped blood loses its oxygen, the fingers turn blue.
Cyanosis.
And finally, as the spasm starts to release, blood rushes back into the area. This causes intense redness or rubor, that reactive hyperemia again. This phase is often accompanied by throbbing, tingling, maybe even painful warmth as circulation returns. White, blue, red.
So if it's a spasm triggered by certain things, management must be all about avoiding those triggers.
Absolutely. Prevention is key. That means meticulous protection from cold, wearing warm gloves or mittens, even indoors sometimes, using insulated drink holders, avoiding sudden temperature changes like grabbing something from the freezer.
Makes sense.
Lifestyle changes too, definitely stopping smoking, as nicotine is a potent vasoconstrictor. Avoiding caffeine might help some people, and being aware of medications that can trigger it.
Like what?
Certain over-the-counter cold medicines containing pseudoephedrine, for example, those are vasoconstrictors and can provoke a bad Raynaud's attack.
And if avoidance isn't enough, are there medications?
Yes, if the attacks are frequent or severe, the main drugs used are calcium channel blockers, like nifedipine. They work by relaxing the smooth muscle in the walls of those small arteries, making them less likely to spasm so intensely.
Okay, let's completely shift gears now. We've been talking arterial inflow, now we move to the other side. Venous outflow. Low pressure, fluid return, pooling, and the acute danger here seems to be blood clots. Venous thromboembolism, VTE.
Yes, VTE, the formation of a clot, a thrombus inside a vein, is a huge public health issue. Lots of hospitalizations, significant risk. And to really understand why VTE happens, we have to talk about Virchow's triad. It's a foundational concept.
Virchow's triad. Okay, what are the three parts?
It outlines the three main conditions that set the stage for a clot to form in a vein. First is venous stasis. That just means blood flow is slow or sluggish.
Like during long flights or being stuck in bed after surgery?
Exactly. Or having a limb immobilized in a cast. If blood isn't moving well, clotting factors can accumulate and start the process. That's stasis. Second is endothelial damage, injury to the inner lining of the vein wall.
From surgery. 4 lines.
Yep. Trauma, major surgery like hip or knee replacement, even just the irritation from an IV catheter can create a rough spot on the vein wall where a clot loves to start. And the third part of the triad is hypercoagulability.
Meaning the blood itself is more prone to clotting.
Correct. This can happen for various reasons. Certain cancers can trigger it, sepsis, some inherited genetic clotting disorders, even things like pregnancy or taking estrogen-containing birth control pills can make the blood slightly more sticky. You often need a combination of these factors, maybe stasis plus some endothelial irritation, for a significant clot to actually form.
Got it. Stasis, damage, hypocoagulability. Now, the notes distinguish between clots in superficial veins versus deep veins. Superficial vein thrombosis, SVT.
Right. SVT is usually less serious. It often happens in those surface veins, frequently related to an IV site that got irritated. The classic presentation is a vein you can actually feel. It's palpable, firm, like a cord under the skin. And the area around it is usually tender, red, warm, and a bit swollen.
And treatment for SVT is mostly local.
Generally, yes. Warm compresses, maybe some NSAIDs like ibuprofen for the inflammation and pain, wearing compression stockings, and encouraging the patient to walk around ambulation helps blood flow. But there's a critical medication note here. Do not combine NSAIDs with anticoagulants like warfarin or Lovenox unless specifically directed. That combination significantly increases the risk of serious bleeding.
Okay, important warning. Now, the more dangerous one. Deep vein thrombosis, DVT. This is in the bigger veins, deeper in the leg.
Yes, typically in the deep veins of the calf or thigh, DVT is a much bigger concern because of the risk of complications. Key signs to look for are usually unilateral, meaning just one leg is affected. You'll often see significant swelling in that leg compared to the other.
Okay.
Plus pain or tenderness, warmth, redness, and sometimes even a low-grade fever, like over 100.4 Fahrenheit. While the DVT itself can be painful and cause leg problems, the real life-threatening danger is what might happen next.
Which is the clot breaking loose.
And traveling through the bloodstream. This is pulmonary embolism, or PE. The clot travels up through the veins, through the heart, and gets lodged in the arteries of the lungs.
And that can be fatal.
Very often, yes. It blocks blood flow through the lungs, preventing oxygenation. That's why recognizing the signs of a possible PE is absolutely critical. The key symptoms to watch for are sudden onset of shortness of breath.
Out of the blue.
Yes, sudden, unexplained shortness of breath. Also, sharp chest pain, often worse when taking a deep breath, pleuritic chest pain, and sometimes coughing up blood hemoptysis.
If you suspect a PE based on those symptoms, what's the immediate action plan? The notes seem very clear on this.
It needs to be instant, automatic. First, call for help immediately. Activate the rapid response team in a hospital or call emergency services. Second, position the patient in semi-Fowler's position. That means head of the bed elevated about 30 to 45 degrees.
Why that position?
It helps maximize lung expansion, makes breathing a little easier, and improves oxygenation. Third, ensure you have IV access or establish it quickly. You'll need it for medications. And fourth, initiate anticoagulation therapy blood thinners as soon as medically directed to prevent the clot from getting bigger or new clots from forming. Every second counts with a suspected PE. Hashtag 4.2 DVT prevention, diagnostics, and anticoagulation.
Given how dangerous PE is, prevention must be a huge focus, especially for people at risk, like hospitalized patients or after surgery.
Absolutely. Prevention is paramount. The simplest and often best prevention is getting people moving early and frequent ambulation. When you walk, your calf muscles squeeze the veins, pumping blood back up towards the heart. It's called the venous pump.
But if someone can't walk?
Then we rely on mechanical methods. Graduated compression stockings, TED hose, provide gentle, continuous pressure. Or more actively, sequential compression devices, SCDs. These are inflatable sleeves that wrap around the legs and inflate and deflate in sequence, mimicking that muscle pump action.
Okay, SCDs. But there's a really important warning about using them.
A critical contraindication, yes. If a patient has already been diagnosed with a DVT, say, confirmed by an ultrasound, you absolutely do not put SCDs on that affected leg,
Why not?
because the mechanical squeezing action of the SCD could potentially dislodge that existing clot, sending it traveling towards the lungs and causing a PE.
Ah, turning a DVT into a PE.
Exactly. So once a DVT is confirmed, mechanical compression on that leg is generally stopped, and prevention or treatment relies on anticoagulation blood thinners.
Okay. How do we diagnose a DVT then? What tests are used?
It's usually a combination of looking at the patient's risk factors, their symptoms, some blood tests, and imaging. For blood work, we might check standard clotting times like APTT or INR, especially if they're already on certain anticoagulants. We also check hemoglobin, hematocrit, and platelet count to assess bleeding risk. But the most specific screening blood test is the D-dimer.
D-dimer. What does that tell us?
D-dimer measures fragments of protein that are released when a blood clot starts to break down in the body. So if the D-dimer level is significantly elevated, it strongly suggests that clotting and clot breakdown are happening somewhere. It raises suspicion for DVT or PE.
Does a high D-dimer confirm a DVT?
Not definitively. Other things can raise D-dimer levels too, like recent surgery, infection, or inflammation. But a normal D-dimer result, the notes say less than 250 nanograms per milliliter, is very useful because it makes a DVT highly unlikely, especially in someone considered low risk. It has good negative predictive value.
So it helps rule it out.
Exactly. But for definitive diagnosis, you typically need imaging. The gold standard is usually a venous duplex ultrasound, which can directly visualize the clot within the deep veins. Sometimes sonography, an X-ray with dye, is used, but ultrasound is more common now.
Once a DVT is confirmed, treatment is usually anticoagulation, right? Heparin, Lovenox, warfarin, or the newer oral ones like apixaban or rivaroxaban.
Correct. The goal of anticoagulation is primarily to prevent the existing clot from getting larger and to stop new clots from forming, while the body gradually breaks down the existing clot over time. In some severe cases, thrombolytics, clot busters, might be used to actively dissolve the clot, but that carries higher bleeding risks. And for patients who can't take anticoagulants or who keep having PEs despite being on blood thinners, sometimes an IVC filter is placed.
What's that?
It's a small metal cage-like device inserted into the inferior vena cava, the large vein that carries blood from the lower body back to the heart. It acts like a little net to physically catch any large clots traveling up from the legs before they can reach the lungs.
Interesting. But regardless of the specific treatment, patient education about safety while on these anticoagulants seems absolutely crucial.
It's non-negotiable. Patients on anticoagulants are living with an increased risk of bleeding, so they need to know how to protect themselves. We teach them specific things, like how to inject heparin or Lovenox correctly, usually in the fatty tissue of the abdomen, rotating sites, and general safety measures. Avoid activities with a high risk of injury. Be careful with sharp objects. Use a soft bristled toothbrush to minimize gum bleeding. And always use an electric razor instead of a blade razor.
Because even a small cut could bleed excessively.
Exactly. A minor nick that would barely bleed in someone else could become a significant problem for an anticoagulated patient. They also need to know the warning signs of internal bleeding to report immediately.
What should they look out for?
Things like unusual or excessive bruising that seems to appear without cause. Dark, terry-looking stools, that's melena, a sign of upper GI bleeding, blood in the urine hematuria, or persistent nosebleeds that won't stop easily. They need to be vigilant partners in monitoring for signs that their blood is too thin so adjustments can be made quickly.
All right, let's move from those acute clotting dangers to the more chronic problems of venous outflow failure, starting with something really common, varicose veins. These look like purely a structural issue.
They are, fundamentally. It's about valve failure in the veins. The veins in our legs have these tiny one-way valves that are supposed to keep blood flowing upwards against gravity.
Okay.
In varicose veins, these valves become weak, leaky, or incompetent, often because of prolonged high pressure in the veins. When a valve fails, blood flows backward refluxes and pools in the vein below it. That pooling stretches the vein wall, making it enlarged, twisted, tortuous, and visible bulging under the skin.
And the risk factors seem to involve anything that increases that pressure in the leg veins over time?
Exactly. Things that put sustained pressure on the venous system. The list includes chronic coughing, chronic constipation, because straining increases pressure throughout the venous system. Also, a family history suggests maybe some inherited weakness in the vein walls or valves. Age, of course. Being female, hormonal factors can relax vein walls. Obesity adds pressure. Pregnancy definitely increases pressure. And a big one is occupations involving prolonged standing.
Like nurses, teachers, factory workers.
Classic examples. Standing for hours means gravity is constantly fighting against venous return, putting continuous strain on those valves year after year.
Symptoms are often more about discomfort than danger. Aching, heaviness, swelling.
Yes, typically. People describe that heavy, tired, aching feeling in the legs, especially towards the end of the day. Visible, bulging, tortuous veins are the main sign. Maybe some ankle swelling. Sometimes nighttime leg cramps are associated too. Diagnosis is often based just on how they look, but a duplex ultrasound can confirm it by showing where the blood is refluxing, flowing backward through those faulty valves.
And treatment starts conservatively. Elevation, compression.
Right, initial steps are usually lifestyle things. Elevating the legs periodically helps drain the pooled blood. Wearing graduated compression stockings provides external support to the veins and helps the valves work better. Regular exercise, especially walking, uses the calf muscle pump to help push blood upward. If those aren't enough, or for cosmetic reasons, there are procedures like sclerotherapy, injecting a solution to scar and close the vein, various surgical options to remove or seal off the faulty veins.
And post-surgery for veins, the focus seems different than after arterial surgery. More about managing swelling.
Yes, because you've intervened on the outflow system. Patients should definitely expect some bruising. The key assessments are still checking color, movement, sensation, temperature, pulses, and especially edema or swelling. The most crucial thing after most vein procedures is keeping that leg elevated, often above the level of the heart as much as possible, especially initially. That uses gravity to help drain fluid and minimize swelling and discomfort. Hashtag 5.2 chronic venous insufficiency, CVI.
So, varicose veins might be unsightly or achy, but chronic venous insufficiency, CVI. This sounds like the severe end-stage result of that venous pressure problem, when the valve failure is really widespread and long-standing.
Exactly. CVI is what happens when those venous valves fail so badly, or there's a persistent deep vein obstruction, that the pressure inside the lower leg veins stays abnormally high all the time. It's chronic venous hypertension.
And that constant high pressure causes damage.
It does. That high pressure deep inside the leg gets transmitted all the way back to the tiniest blood vessels, the capillaries, especially around the ankles. This intense pressure forces fluid, proteins, and even red blood cells to leak out of those capillaries into the surrounding tissues.
Leading to constant swelling.
Right, chronic edema, and those leaked red blood cells break down, releasing iron, which stains the tissues. That's what causes that characteristic brownish, brawny discoloration of the skin around the ankles, often called stasis dermatitis. The skin also gets inflamed, dry, and itchy venous eczema.
And the skin itself becomes fragile.
Very fragile. It's malnourished because of the poor microcirculation and stretched taut by the edema. This sets the stage for serious complications. Recurrent skin infections, cellulitis, lymphedema, secondary swelling due to lymphatic overload, and the most common serious complication, venous leg ulcers.
Ulcers caused by the poor venous drainage.
Yes. These typically occur in that gaiter area, above the inner ankle bone, medial malleolus. They tend to be shallow, weepy, irregular in shape, and can be quite painful. And because the underlying tissue health is so poor, they are notoriously difficult to heal and prone to recurrence. If they get badly infected, they can ultimately threaten the limb.
So the focus of care for CVI must be relentless protection and trying to counteract that pressure.
Absolutely. Two main goals. Protect that fragile skin from any kind of trauma. Even a small bump or scratch can break the skin and lead to an ulcer. And aggressively promote venous return to reduce that damaging pressure.
And the notes give a very specific protocol for leg elevation. It's not just put your feet up when you can.
No, it needs to be more structured. The recommendation is usually to elevate the legs above the level of the heart for about 15 to 20 minutes, ideally 4 times a day. This is active therapy time.
Okay, and for sleeping?
Elevate the foot of the bed by about 6 inches, using blocks or risers under the bed frame itself. Just putting pillows under the feet often doesn't work as well or isn't maintained all night. This uses gravity consistently throughout the night to help drain the fluid that accumulated during the day.
And compression is key too.
Essential. Wearing prescribed graduated compression stockings or bandages every day is probably the single most important thing to manage CVI and prevent ulcer recurrence. They need to be put on first thing in the morning before getting out of bed if possible, when swelling is at its minimum, and worn all day.
Any other posture or clothing advice?
Yes, avoid anything that constricts flow. No crossing legs for long periods. Avoid tight clothing, especially around the calves or waist. And avoid prolonged periods of just standing still or sitting still. Encourage frequent movement, ankle pumps, short walks to keep that calf muscle pump working.
Finally, if an ulcer does develop, managing it seems complex. The notes mention collaborating with a dietitian. Why is nutrition so critical for healing these venous ulcers?
Because healing a chronic wound requires a huge amount of cellular activity and building materials. Venous ulcers might have adequate oxygen supply, unlike arterial ulcers, but they still need the right nutrients to repair tissue. The sources specifically flag the need for adequate protein for building blocks, vitamin C, crucial for collagen synthesis, vitamin A for epithelialization, and zinc, involved in enzyme function and cell replication. If the patient is malnourished, particularly low in protein, that wound simply will not have the resources it needs to close.
Makes sense. And what about dressings and antibiotics for these ulcers?
Dressings for venous ulcers aim to maintain a moist wound environment, which promotes healing. They also often incorporate compression. They might be left in place for several days, sometimes 3 to 5 days, to avoid disrupting the healing bed too often. And a really important point about infection. Routine use of antibiotics just because an ulcer is present is not recommended.
Why not?
Most chronic wounds will have some bacteria present, colonization, without being truly infected. Overusing antibiotics just breeds resistance. Antibiotics should only be used if there are clear clinical signs of infection, increased redness, spreading away from the ulcer, more pain, pus, fever, and ideally guided by a wound culture identifying the specific bacteria. The core treatment for the ulcer itself remains compression and addressing the underlying venous hypertension. Hashtag outro. So if we pull all of this together, looking back at everything we've discussed, maybe the single most important thing for listeners to take away is that fundamental difference we started with. Arterial versus venous. PAD is about inflow failure, oxygen starvation, ischemia. The pain gets better with rest.
Okay.
CVI is about outflow failure fluid and pressure backup, stasis, edema. The discomfort, the swelling gets better with elevation, rest versus elevation. If you can keep that core distinction clear, you've got a solid handle on the basic physiology driving these different PVDs.
That's a great summary. Rest for arterial, elevate for venous. And that clarity really helps make sense of all the details we've unpacked today. We've gone through the sources, covering, well, everything from that specific pain of claudication
And how collateral circulation develops.
to Virchow's triad for clots and those really crucial safety rules for anticoagulants. Hopefully you feel like you have a much clearer map now of these peripheral vascular disorders.
And throughout our discussion, we kept seeing how those systemic issues, high blood pressure, high cholesterol, diabetes, smoking, act like accelerators, right?
Yeah, turning what might be slow changes into really serious limb-threatening disease much faster. Which brings us to our final thought for you, the listener, to maybe mull over. We know that many of these conditions, especially PAD, often result from decades of accumulated damage before they even cause symptoms. So consider this. How much less common would things like critical limb ischemia, amputation, or those awful venous ulcers be if those core modifiable risk factors, the smoking, the diet, the blood pressure, the blood sugar, were managed aggressively, not just when someone's in their 60s or 70s, but starting way back in their 20s or 30s?
The power of lifelong prevention.
It really highlights the potential impact of tackling those risks early, potentially averting these peripheral disasters decades down the line, something to think about.
A powerful thought indeed. Focus on vascular health across the lifespan.
Absolutely. Until next time on The Deep Dive, keep digging deeper.